Hi, everyone. Thank you for joining the training this afternoon. We are going to go ahead and get started. This training is presented by the Ohio Chapter American Academy of Pediatrics, the Parenting at Mealtime and Playtime program. We'll be discussing promoting cognitive and social well-being throughout childhood and navigating screening questionnaires with Dr. Kate Crick. I just wanted to give a little overview of some of the things that we're doing with the Parenting at Mealtime and Playtime program. We've had 4 well child visit support series, and then we also have had 4 practice management trainings. We have 1 training left on March 8th, and that is the mental health training. So if you have not registered for that yet and you're interested, the link to register is there on the screen. We have also launched a Pmp Toolkit with nutrition activity modules and advice for you to utilize. There's an online version and a Word doc version. And then we also have the Parenting at Mealtime Playtime Journal Club, where physicians can earn 20 MOC Part 2 and 20 CME credits. This is what the Pmp Toolkit looks like, and you can register for the toolkit using the link there. We also want to thank the Ohio Department of Health for their support with these trainings. If at the end of the training, you will receive a survey to receive your CME credit or your certificate. We also have Pmp Resources available on the website or the mobile app that can be downloaded on Apple Store or Google Play. There's handouts, age-specific handouts, and topic-specific handouts. So all of that information is available on our website or on the mobile application. A couple Zoom tips, please keep your lines muted. You can ask questions and comments by typing into the chat box. Dr. Crick will take questions throughout the training. So if you have a question, I'll let her know during the training and she'll go ahead and answer that. So please let us know. Don't share your video. And if you have trouble hearing or seeing the presentation, please let us know in the chat box and we will try to get that fixed. So I will go ahead and pass it over to Dr. Crick to introduce herself and get started.
Hi, so I'm Dr. Kate Crick. I've been on a lot of virtual meetings, but I've never really been the presenter. So this is kind of a unique experience for me. I was thinking, like, what's the best background in my house? And I have some like cool glass trim stuff, but like then I'd be standing in front of a door or something. So this is my dining room. It could not be more boring, apparently. You can't see anything except the back of the screen. So if I present for you again, next time I will try to get something more visually appealing for my background. I'm not that far ahead of things yet. So I have no disclosures and no off-label products will be discussed. Just a short background on who I am. I'm a general pediatrician in the Columbus area. I just made a life change from after 18 years of private practice pediatrics. I just started a new position at Nationwide Children's Hospital as an associate medical director at PFK, or Partners for Kids, which my role is quality improvement for our community practices. So as a longtime general pediatrician, I definitely have been through my fair share of various screening questionnaires and what works better and what doesn't work as well, and can I find a new one that would work better, and sometimes design my own, and incorporated a bunch through quality improvement projects, many of which were through the Ohio AAP. So I think just the general pediatrics plus the quality improvement experience is what puts me in a position to be able to at least discuss kind of it's really more of a broad overview of these questionnaires. We'll go through specific questionnaires, when they should be used, what are the recommendations, what do we know about them. I am not a data specialist, and I am not a researchy type person. So I'm happy to take your questions, but I come from a clinical background. And so often will not have the answer to things very specific to, details of how a questionnaire was implemented, or that's not true, but how a questionnaire was developed or that kind of stuff. Feel free to ask though, if you have any questions. This is not a master list. These are some examples of things that are used frequently in practice, but by no means is this an exhaustive list of everything that's out there. Let's see if I can actually advance my screen here. Oh, all the screen advancement just disappeared. Hang on. Oh. I think this is my next slide. I think I just went one. So the objectives of today's, we're going to describe current AAP recommendations for preventive screening in childhood, demonstrate a variety of tools that can be used to meet these recommendations, discuss how to implement preventive screening into a busy practice, and discuss appropriate coding to reimbursement of services for preventive screening. I promise I will not read every slide to you. See, I don't have the, Alex, you'll just have to go ahead and advance for me because mine just keep disappearing. So I was tasked with coming up with a sort of manageable list of things that we can screen for. And it was thought maybe like a top 5 list. Well, I ended up with a top 6 list. Obviously, there's 10 million things you could screen for. This is the stuff that I found kind of most frequent in general pediatrics. It's geared towards well child visits and screening questionnaires to identify concerns with cognitive, emotional, social, behavioral, developmental issues. And so that's how I came up with this list. Is it's not kind of disease specific and it's not an exhaustive list, but it's just a decent list of what the AAP expects us to do at well child visits. So for the clinicians in the audience, obviously you're going to fit this right into your well child visits. And that's how I have this presentation arranged, since that's what I do. But I realize that there are many other types of people. I don't know what word to use. I'm sorry, I'm being lame. Anyway, there are many more of you out there that are not clinicians, but engage with children on a very regular basis. And I think that you'll find at least a few of these questionnaires are very pertinent to what you do. And I hope to give you the ability to sort of pick and choose which you want to use, which you think will be pertinent to whatever your practice is, and how to implement them in a systematic way, regardless of whether you're in clinical medicine or not. So you can go ahead. Okay, so we're just gonna go forward. So the first one is depression screening. This is actually why I get away with top 5, is because maternal depression screening and adolescent depression screening are done pretty much the same way. There are some differences, and I'll talk about those differences. But in terms of screening tools, implementation, billing, we'll get to billing at the end. There's a lot of similarities between these two things. So I chose to talk about them together. So you can see for each of these kind of subject categories, each of these questionnaire types, I've put in the American Academy of Pediatrics Bright Futures recommendations from 2020. It might be 2019. Anyway, I don't think they've changed. So maternal depression, they recommend that you screen at 1 month, 2 months, 4 months, 6 months, and adolescent depression, 12 to 18 years. Next slide. Okay, so depression screening tools. These are the 3 that I'm going to focus on. There are others. I can say that 99% of what I've read and heard through presentations uses one of these 3. So next slide is the Edinburgh Postnatal Depression Scale. You can go to the next slide. EPDS, this is just for maternal depression, as it states, Edinburgh Postnatal Depression Scale. So it's for maternal depression only, you can't use it for adolescent depression. These slides, I know this is really tiny print. It's not something that you need to be able to read any of the details on. I just want to give you a visual of what that questionnaire, what each questionnaire looks like. All of these questionnaires, in addition to a couple of links and this presentation itself, will all be made available to you at the end of the presentation through a shared folder. So you will have access to view, print, whatever you want to do with any of these questionnaires, as well as the slideshow. So kind of big picture of the EPDS, it's 10 questions. With each of these, I tried to sort of give you a sense of how long it is, how onerous it is, how good it is, how useful it is, how much work it takes to score. So you'll see kind of common themes as we go through. So this is 10 questions, and in general, 10 is a pretty decent amount. I mean, it's definitely not too large and not too small, and doesn't take a huge amount of time. Okay, and then the answers, the parent, so it actually says there on the top that the parent, it's actually the mother, because it's the maternal depression screen. Answers how they have felt in the past 1 week. Each item is scored 0 to 3. So even though you can't really see the details, there are 4 possible answers for each question, and you would score them 0 for the first answer, 1. Actually, it tells you on there, as I'm like squinting to see the picture, it tells you how much that answer is worth, and then you add up all the scores. So a lot of them are going to work just like this, where they have like a 0, 1, 2, 3, or a 1, 2, 3, 4, and you add up all the scores at the end. Don't go yet, but I think the next one is going to be there's no score sheet on this one. So the total score, so after you add them all up, total score of 11 or above is suggestive of postpartum depression. There was a lot of different data about what if you use different cutoff points, and you, depending on what you do, if you make it 12 or you make it 10, that can increase the sensitivity but decrease the specificity. So it seems like a score of 11 had sort of the best mix, is what I read, the best mix of sensitivity and specificity. So at this, the sensitivity is 81% and the specificity is 88%. So I am not a statistician, and I get confused about these things all the time, but just as a review, sensitivity is how likely are you to pick up if there's a problem. And so 81% means 81% of the time you actually picked up a positive that is a positive. Well, that's kind of positive. Anyway, sensitivity is, did you pick it up on your screen? specificity is how specific is it for the disorder. So like on an EPDS, for example, maybe you picked up, somebody has generalized anxiety disorder. That's not actually what you were looking for. So that it picked up something, but it didn't pick up specifically what you were looking for. You want those numbers to be, and it depends on what you're talking about, but higher. The higher, the better. So 81% and 88% for this tool was sort of the best mix that you could get with a cutoff score. And so that's how the cutoff score becomes 11. But there are definitely, it's not versions, but literature out there that says, well, you can use this score, you can use that score, and here's what it does, depending on, are you trying to, pick up every possible case, or are you trying to be incredibly specific for what you're doing? Bottom line, if you want to use this tool, it's a fantastic tool. It's relatively easy for a parent to complete in a short amount of time. And you can use using a cutoff score of 11, anything 11 or above would mean that there is the possibility of, it's a positive screen. This person might have postpartum depression. All right, you can go to the next slide. So PHQ-2, this is actually the first two questions of the PHQ-9. PHQ stands for Patient Health Questionnaire, 2-question version, and then the 9 is next, is the 9-question version. The 2 is a valid screening tool. The 9 is also a valid screening tool with more questions, but can also be used for helping you, aiding in the diagnosis, following treatment, efficacy. So there's the 9 is kind of the more thorough questionnaire. It obviously takes a little more time to fill out. It's going to give you more information. But as a screener, if you're screening every single adolescent, or maybe where you are, you need to screen everybody you see, PHQ-2 is good because it's just short and quick, and it does give you a good idea. So you can see 2 questions. Answers should reflect the past 2 weeks, and that's written on the screener. Same deal with a score of 0 to 3, you add them up, and if your total score is 3 or above, then it indicates that there's a need for further evaluation. Now, if you're using the PHQ-2, further evaluation could include the PHQ-9, but obviously for all 3 of these, further evaluation for a positive screen for depression means you need to get some help. So if it's the mother who's not my patient, I generally will refer them back to their gynecologist or their obstetrician, or even community resources if that's not something that they have kind of easy access to. And then for adolescents, we do take care of many adolescents with depression. And so if you don't, obviously you could refer them out for more thorough evaluation, or if you're comfortable treating depression, you could do the evaluation yourself. So a couple of things with this questionnaire. One is specific to the PHQ-2, which is the first question. Kids always kind of get that wrong, and that sounds bad to say they're wrong, but it says little interest or pleasure in doing things, and they'll put nearly every day. So I just have gotten in the habit of asking about that. I can't change the question because it's a standardized questionnaire, a validated questionnaire, but so if they put nearly every day, but they put 0, so 3 for 1 and 0 for 2, those are not really consistent with each other. So I'll say, this means things that you normally enjoy doing. And then they go, oh, I thought it meant like chores. So that's not what it means. Then they're like, oh, it's a 0. Anyway, so I just, keep that in mind. I do like this questionnaire because it's so quick to get kind of a heads up. I definitely have had patients who nobody had any idea were struggling, and they've scored high on this. And then we've gone on to do further evaluation. And treated with, behavioral therapy and medication. The other thing I was going to say just in general about depression is, so the other thing that, that seems daunting is, if you get a positive when you're not expecting it, that's overwhelming. How can you possibly manage that? It depends on the setting that you're in. So in a general pediatrics practice, these were my patients. I knew them, I knew their families. I could see them regularly. So I could sort of survey, okay, where are we at right now? How much risk is there? How bad are you feeling? Is there suicidal ideation? Do you feel safe? Do you have access to firearms? Mike Gittleman would be thrilled that I just threw that in there. Obviously, if the answer is to a suicidal screen is positive, that your day is shot. That's just how it happens. But that kid needs you more than any other kid that you're going to see that day. So you just deal with it. But most often, it's really just identifying that, okay, there does seem to be some emotional concerns here, and we really need to take some time to figure out just how significant this is and create a treatment plan. And 9 times out of 10, parents were happy to come back in a couple of days or make a telehealth appointment during my telehealth time, or they were happy that it was identified and that I had a plan for how we were going to manage it. And then I worked out ways to get them back in a reasonable time, rather than spending an hour and a half with a 15-minute well visit, which would, then throw off my whole day. So it can be done. Pediatric Associates is where I worked for 18 years. We have 25 physicians and 4 offices across Columbus. We implemented the PHQ-2 years and years ago. It works well. It's definitely possible. Okay, so the next one is the PHQ-9. Another questionnaire I actually really like and use a lot. So you can go ahead.
Dr. Craig, we had one question for you. So what are your thoughts on using the PHQ-2 to start for maternal depression screening and then doing a full Edinburgh if positive, trying to decrease costs to families by screening so frequently in the first 6 months?
So I love that idea. Actually, thank you for bringing that up. At Pediatric Associates, we actually did use the PHQ-2 for maternal depression screening. The reason we decided to do that was because the Edinburgh, it just is longer. It's 10 questions. PHQ-2 is 2. We implemented adolescent depression screening first with the PHQ-2, and so then it was pretty seamless to add that to maternal depression screening. It's still a really good tool for, are we totally fine, or do I need to ask some more questions? And then I think that the Edinburgh is a great follow-up, just like this PHQ-9 that we're about to talk about is a great follow-up for teens. Notice this one says modified for teens, but I think that's an absolutely excellent idea. It's quicker, it's kind of less onerous on the parent. I think that's perfect. Thank you for bringing that up. All right, so PHQ-9 can also be used as a screener. You can see it's 9 questions. Actually, it's called the PHQ-9, and this one has 10 questions. It came from the original PHQ-9, which was 9 questions, and then it's been modified specifically for teenagers. Same idea as the PHQ-2, just more questions. You add up the number of points, and then a score of above 10 is suggestive of major depressive disorder. I kind of skipped the sensitivity and specificity, but I'm just gonna, that's on there for you guys to look at. I tried to only pick questionnaires that were pretty high in terms of sensitivity and specificity. But everything I'm presenting has been standardized, validated, and is out in practice. The other thing and I don't know if it listed it at the bottom. I'm sure it did, because I'm sure I put it on every slide, that there are some questionnaires that you do need to get permission. Some you need licenses, some you have to pay for. So I tried to add that to the slides about another thing. I think the EPDS is, yeah, I don't think you need any license or anything, but the PHQ-2 obviously is very, very easy to reproduce. Free, no license or permission needed, and same with PHQ-9. So PHQ-9 can be used as a screener. PHQ-9, I more often used that to follow up for a positive screen. And of course, in my patients who had known depression, you can use it to see how well their treatment is working by a decrease in scores. So another option. All right, you can go forward. So that's developmental screening. I'm like, oh, I just did one topic in 20 minutes. This is going to take me way longer than I had realized, but this is a good place to just say, if anybody has any questions, go ahead and throw them up in the chat box. If you feel like there's kind of an area that I'm not addressing that is pertinent to you, throw that up on the chat box. Let me know if there's something a little different that I can present, or more information needed as I go through. These are all going to follow the same format. So the next recommendation from Bright Futures is developmental screening, and it's recommended at 9, 18, and 30 months with a standardized validated questionnaire. You can go on to the next slide. These two are by far the most used. There are many out there, and there are, as I was putting this together, realized like there's 3 or 4 that I think might even be better options, but I'm not as familiar with them. I didn't really hear about anybody using them. But if one of these doesn't work for you, there's a lot of stuff that's out there that is standardized and validated and counts. So, you know, don't be sort of boxed in by what you see here. My practice used ages and stages questionnaire. We actually, when this recommendation got implemented, we actually tried out the PEDS, and you'll see it's a very kind of generic, vague questionnaire. And while it's got good sensitivity and specificity, we kind of felt like we weren't really doing very much. And when we started charging for developmental screening tools, we didn't really feel like the PEDS, it just felt too vague. But the reality is it actually works very well. It's very easy. And it does meet the criteria for billing. So don't knock it just because I did. But we chose the ages and stages, which is much more thorough and time consuming, because we felt like that was more specific, though I don't know that the sensitivity is any better. Next slide. So the ages and stages, this slide is totally overwhelming. 3, it's the 3rd version. I put up, so the ages and stages is age specific, and it goes through, I want to say 6 topic areas. Well, let's see. It's communication, gross motor, fine motor, problem solving, and personal social. So it covers all of development. Pretty specific. You know, the questions, you're not going to be able to see them on there, but the questions are really specific to what should a child be doing at this age. There's a couple that are like stretching to the next age group. That last one with more black on it, that's the scoring sheet. So basically they circle in the bubble. It's yes, sometimes, and no, not yet, I think is what the other one is. So they circle in the bubble. Are they doing this? Are they sometimes doing this? for all of these, you get 0 for not yet, and 5 for sometimes, and 10 for yes. And then you just add them up. So it's pretty easy when you're looking at the communication. I don't remember exactly how many. It looks like there's 5, 4, 5, 6 questions. So I got like 10, 15, 25, 35. Okay, that's my score. And then you would look on that last sheet where the black lines meet the gray lines, and wherever your 35 or whatever your answer is, it tells you, are they in the borderline range? Did they pass or did they fail? It's really, it's kind of overwhelming to look at. It's really a good tool. Parents, I think, I've never had a parent say, I'm not going to fill that out, even though it's pretty long. This is what they love. They love this stuff. They love finding out, what should my kid be doing and what are they doing? And do you have any concerns about this area? And so they recognize these questions as really kind of standard of care of what pediatricians should be doing. And I realize you're not all pediatricians. So, but this is, childhood development. That, probably everybody on this call right now has a connection to childhood development. And this questionnaire is a really good way to get very specific and yet kind of clear-cut answers. So it's pretty easy to say, if somebody is concerned about their child not having a lot of words at 18 months, it's pretty easy to say, yeah, I share your concern from their results, or wow, they're really doing everything they should be doing at this age. So it helps me feel better about kind of the blurry lines of development. And I know parents, when I point out what this questionnaire is telling me, that they really enjoy this questionnaire. There is a web-based version. In private practice, so you do need a license. You have to purchase a license to buy the toolkit, and then you can replicate it as much as you want. I think that it's more to purchase the web platform, but we had our patient registration system deliver this electronically to patients who were coming in for the right type of visit. And this could be completed online before the visit, which was awesome. It wasn't always, so sometimes we were giving it out in the room as well. But that's another thing that just takes a huge amount of, it's not a huge amount of time, but my time was incredibly limited. The parents' time with me was limited. And so to have them filling out questionnaires, while I was kind of waiting on them is not always ideal. This was really nice when parents would take the opportunity to complete it ahead of the appointment. And then just as I'm looking through the chart, prepping for the appointment, pretty easy to see the scoring. You don't just get the score, you actually get, well, now I take it back. I think you get the whole questionnaire as in your scoring. I think it documents the whole questionnaire. Anyway, electronic version available, saves a ton of time, lets me know if I can go in and say, wow, all the development looks absolutely fantastic. I have no concerns whatsoever based on your questionnaire. Thank you for filling that out. Versus, okay, we're going to have to spend a fair amount of time discussing this area that I'm concerned about. It just really streamlined visits with developmental concerns. All right, go ahead to the next one. In contrast, so this is the PEDS. It is, it's very general. These questions are, look at me trying to look at it on my screen, but they're like, do you have any concerns about this? Do you have any concerns about that? Do you have any concerns? And it's not specific to these, like developmental milestones. It doesn't have to do with, it's just saying, do you have any concerns about development? Do you have any concerns about hearing? Do you have any concerns about learning? And I guess you can see it is less sensitive and specific than the ASQ. and it feels less sensitive and specific. It's still, I mean, the AAP says this is a completely valid way to do standardized screening for development. And I guess if you think about it, what we always did before we had screening tools was just surveillance, like, hey, is your kid walking yet? And this really is probably better than that, because you're specifically asking for parental concerns. The research has shown that parents are really good at they might not know what the problem is, but they're actually quite good at knowing if there's a problem, at identifying a concern for a problem. So this questionnaire would draw your attention to the area that the parent is concerned about. If you just say in general, like, do you have any concerns about your child today? You're probably not going to get these answers, but it's, you know, a little more detailed than, do you have any concerns about your child's vision? Do you have any concerns about your child's development? So it is definitely better than surveillance, and definitely better than just kind of general, do you have any concerns? And based on what the concern is, on this questionnaire, then you would need to kind of figure out what the next best step is. So you have to figure out your plan of action for both of these questionnaires, but I think with the ASQ, it's a little more defined, like it's this area and not any of these other areas. And when that happens, we do this. Regardless, it still is a good questionnaire. It's very easy for the parents to fill out. Obviously, it takes less time than the ASQ. Easy to score because you're just looking at, do you have concerns or not? But then based on their answer, you have to delve into it quite a bit more to kind of find out, is it really a concern or not? This one, so the scoring is provided in the PEDS Guide to Administration and Scoring. I don't think that's on the next slide, but it is in the shared folder that you'll get after this. Why don't you go to the next slide? Yeah, so there's a whole like book of scoring. It's not a book, but it's, you know, 8 pages or something on how to score. And it basically is just giving you algorithms on, you know, if they say yes to this, then you have to ask questions about this. So that is something to take into account, is, you know, like I said, it's easier, it's less time consuming when the answers are no, but it's a bit more time consuming because you have to really delve into all the specifics when the answers are yes. And that is available on the shared folder that you'll get at the end of this, so also available to you. So moving on, I don't see any questions flying up. Autism. Actually, why don't you go back to the previous slide? There should be one. Yeah, so Bright Futures recommends autism-specific screening at 18 and 24 months. This is not the same as using an ASQ3 with the personal and social section. There's the personal social section. That's not, I mean, they're kind of getting at, but autism-specific screening has to be a questionnaire that's been validated for autism specifically. Okay, so next slide. This is another one where there are actually quite a few options. The one that everybody knows about is the MChat, and this is the revised and follow-up format, which is what is expected to be used. And we'll talk a little bit about what that means. The one that my practice used since the beginning of this recommendation is called the ITC, or we called it the ITC Infant Toddler Checklist, but it actually comes from this broader tool called Communication and Symbolic Behavior Scales Developmental Profile Infant Toddler Checklist. You can see why we called it the ITC. So we'll talk about both of those. There are many others that actually are validated for identifying autism. Some of them are more lengthy. I looked through and I was intrigued by many of them. But the length was kind of the thing that kept me at these two, and the familiarity I had with the ITC and the MCHAT. So moving forward, the MCHAT R, I didn't put the follow-up on because that's on the next slide, but the R part of the MCHAT just means that it's been revised from the original MCHAT. And so if you're going to use the MCHAT, you need to be using the R version, and it's these 20 questions, and whether a yes is a pass or a no is a pass, and vice versa. That's on the scoring sheet. So it's not like you can just look at it and count it up. Although when you've used it 12,000 times, you can just look at it and count it up. This is validated for autism from the ages 16 to 30 months of age. Now, it was originally, I don't know if designed or validated is the right term, but originally there was a much it was indicated for an earlier age, and it didn't go up to 30 months of age. But this revised version, when you're specifically looking for autism, it's found to be predictive in this age group, 16 to 30 months. So keep that in mind, that the age groups for autism-specific screening are 18 and 20. There are autism screeners that can pick up early signs of autism earlier than this, but the MCHAT is not one of those. So the MCHAT is designed to be used at these little bit older ages. All right, so 20 questions, pass, fail, and then you basically count up how many fails there are, and that comes from your scoring sheet. And then if you have 0, 1, or 2 fails, no further action is needed. They've passed that. And then a score 3 through 7. So I think this is interesting. I usually the score is 0 or 1, and you'll occasionally get a 2, 3, or 4. So 3 to 7 is that middle category. That's when you would use the follow-up interview, which is a little overwhelming to look at, but it's pretty intuitive to actually do. And if you get a really high score, I've not seen one of these really high scores. I also don't screen my kids with known autism at these ages with this screening questionnaire. So it would be different if you actually looked at kids who were identified with autism. So a really high score, they say, just go ahead and refer them for a diagnostic evaluation and early intervention, because you just don't see these scores. If the score is this high, it's obvious that this kid needs some more intervention. So go ahead and make those referrals, and don't waste your time on sort of teasing out the details. So for identification of autism spectrum disorder between 16 and 30 months of age, the sensitivity is 91% and specificity is 96%. So that's high. Talking about sensitivity and specificity. It's very specific for autism. It's very sensitive in that it doesn't miss many cases. It is copyrighted, but it's free of charge for clinical purposes. So very easy to obtain. It's a lot of questions. I don't find this to be an overwhelming number of questions for parents to complete. Next slide. So this is the follow-up, the F part of the RF, and there are pages and pages and pages that you could actually read that look a lot like this. This is basically number 1 question. If they failed number 1, you would go to this algorithm, and it tells you what more to ask about based for this specific problem or question fail. It's all obvious stuff, like, if really read it enough to think of a good example of this one, but you know, if they're not pointing at things, right? Then you ask more questions to find out, do they actually try to get your attention in another way? Or are they really just, they're not trying to get your attention at all? So it definitely can be helpful if there's a question that you're like, I'm not really sure how to follow up on, but a general conversation of, let me get some more details of this specific item to really decide, did they really fail it, or are they just doing it maybe in a different way, or maybe parents didn't even really identify. A lot of times if there's something that I'm like, okay, so tell me a little bit more about why you put this answer for this one, and then as they're explaining it, I'm like, oh, that's totally fine, they've passed. Or sometimes the kid will actually do something for me, not because they know what I'm talking about, but they just, you know, share, oh, did you see they just pointed out that little bug on the wall? Hopefully we don't actually have bugs on our walls. So there is an algorithm that you go through using flow charts, asking questions to decide if it's a true pass or a true fail. And then, so negative screen or positive screen. And then what you should do. So if you go through the follow-up and no, actually they didn't, they actually passed on follow-up, then you're fine. And if you go through and you're like, I really cannot get them to make me feel comfortable that they're passing this item. If you have 2 or more on the follow-up interview, then again, you would refer for diagnostic testing and early intervention. That's enough to say, okay, no more messing around. Let's just get them in and get them evaluated to see if they really do have it. All right, next slide. Okay, so this looks really overwhelming. This is the ITC, or the CSBS-DP ITC. It is a lot of questions, and they are actually printed quite small. It all fits on a page. So my dog is clearly barking at whatever's outside. I don't have any way to stop my dog from barking. Oh, there's another 2 dogs being walked. I apologize. So this questionnaire is really good. We use this mostly because I said we should use this. It's a lot of questions, but like the ASQ3, it's really specific, and parents, as they're filling it out, they can actually really tell that you're asking all the right questions. So as opposed to asking about general development, this one is asked, this one is asking specifics around, it's not just autism, but autism is an area that it focuses on. So it's actually a language-based questionnaire, and that broader toolkit, the CSBS-DP, it's a developmental toolkit, and this is their language-based part of it. And so it's broken down into 3 sections. I probably have the scoring sheet on the next slide, but hold on to this slide. The first 3 sections are looking at kind of stuff that's more specific to autism. And so that's like, did they pass or fail that section? And then the next 2, sounds and words, are expressive language. And then the last 2 are understanding and object uses, receptive language. So it's really, even, you know, I use this for autism-specific screening because it is validated for that. But I also use it at 12 months for language development, 12 and 18 months for language development, because those are the ages I think that there's a lot of variation between my kid is not saying anything and my kid is saying a lot, and parents are concerned at those ages. And so it's nice, like the ASQ3, it's nice to be able to say, well, let's look at these specific parts for her age, she is actually right on track for how much she's using language and how much she's expressing language. So you can see for the autism part of it, identifies 93% of infants and toddlers with later diagnosis of ASD, but it's not specific for ASD. That's as close as I could get to sensitivity and specificity. But like I said, you can use this, it's language-based, so it's not specific for ASD, but we know that ASD has a language component to it in the first 3 sections that I didn't read out. Well, I think it's on the next page. Why don't you go ahead to the next page? So the score sheet breaks it down into these 3 sections. Those are the composites. So communication is those first 3, and that includes emotion, eye gaze, communication, and gestures. Obviously, that's kind of narrowing in on deficit seen with ASD. And then the expressive speech, sounds and words, and then symbolic speech, or symbolic understanding and object use. So it's broken down into 3 areas. You count up the score for the 3 areas, and it's obvious how you count from the original page. Like, it tells you how many points you get for each thing. So you count up in each section, what did they get, total up those 3 sections, and then this score sheet tells you what are the thresholds for each age group. So if you're using a 12-month-old, then they need to get a score of at least 14 for communication to pass the autism screening portion of this. But if that kid is 18 months, it's the threshold of 18. So you can see that how much the kids are doing obviously depends on their developmental kind of age, and as you get older in age, you ought to be doing more, and that's reflected in the score sheet. So this tool makes my job easier, and this, I would say the same thing for the ASQ3. These are a huge number of concerns of parents that it's very easy to quickly say, wow, look how good they did on this score. I really have no concerns at all. Or, there is some reason to be concerned. Let's really figure out more about this and how we're going to proceed with an evaluation. I feel like babies, so those little kids from, 2 and under, a lot of the concerns, parental and clinically, are autism and developmental, if they're going to have concerns. And those can be really challenging to sort of address and evaluate and kind of come to some sort of assessment and treatment plan, even when everything is normal. So these questionnaires really, they make my job easier. This one is long, and it is like, some parents are like, oh, I didn't bring my reading glasses, but really, I don't think I've ever had anybody refuse to fill this out. And again, I think it's they get how useful this is. They see the questions and they're like, okay, yeah, this is really important to be filling out. They do refuse to fill out other questionnaires, but not these. I think that's it for the ITC. I would assume if anybody had any questions, they'd be in the chat box. So moving on, substance use. Bright Futures recommends screening for substance use ages 12 years to adult. So essentially the same time that you're using your depression, adolescent depression screening. Next slide. I didn't give you any options here. There really couldn't really find a lot of options. This is the one that everybody talks about. I will admit that this is an area that we didn't get good at in my practice. So we did create a adolescent questionnaire, younger adolescent and an older adolescent, and incorporated tools like PHQ-2 and Healthy Habits Survey and some other stuff, and then just wrote in some questions asking about substance use and sexual activity and that kind of stuff. But it didn't follow a validated questionnaire. So if you're going to use a validated questionnaire, and that is always preferred, this is the one you use. So it's called CRAFT, and that stands for the questions in the original version were about car, relax, alone, forget, family, friends, trouble. And you'll see that on the next slide. So manageable, 9 questions. It actually tells them like, so everybody has to answer the first 3, and then I think everybody has to answer the 4th, but you answer all of them if you had some answer. It's all right in there. I know you can't see all the details on this slide, but it's incredibly instructive to the adolescent completing it or the clinician giving it, how exactly to fill this out. Validated, they're to complete it based on their experiences in the past 12 months, high sensitivity and specificity for use. So pretty straightforward and very easy to use. The challenge, the trick is what to do when it's positive. So next slide. Look, I did put it in here. So this is just the scoring. You know, you're allowed to get one of those sort of wrong, right? You're allowed to say you once did that and we're not concerned about a problem. But if those start adding up, then the way it's designed is it doesn't mean you have a substance abuse problem. It doesn't mean that you are an abuser. It means that there's a potential of a significant problem. It doesn't mean, you know, if you pass, it doesn't mean there's 0 chance that you have any issue. But if you have 2 or more positives, then there's an increased likelihood that there may be something going on. And so it would require further assessment. I would say this is probably the reason why my practice wasn't as good about doing this one as the others is, well, in part because I'm the one who designed it for them and I wasn't good about this one. But the reason I wasn't good about this one is because I feel kind of like I don't have a lot of options. So I know that there are community programs and I know that there are specialty programs, and the original CRAFT actually included brief intervention where you did your own sort of counseling on risk. The reality is that, you know, I have a really hard time getting kids into treatment programs, mostly because they have 0 interest in doing it, but also because there aren't really good programs for kids. So I could be totally wrong. And if any of you know of anything out there, throw it up on the chat board just for my own information, that there's really fantastic programs and this is what it is, or this is where we can find more information. We should be doing this. I wasn't doing a great job of this. I'm now not in private practice anymore, so I guess that puts me off the hook, but I am in quality improvement. And so this is an area that don't forget about it. Next slide. All right, I think this is the final section. Well, it's not, it's the final screening, and then we'll have some examples and stuff, but it's the most overwhelming as far as I'm concerned, and the slides are going to be the most overwhelming too. So social determinants of health. These are all the things in our life that are not clinical, not specifically medical in nature, but impact. That's my husband making lots of noise, by the way. I could yell at him to stop making noise. See if he continues. So social determinants of health. So things in your environment that affect your long-term health, your lifespan, your you know, how the quality of life that you lead. and will lead for the rest of your life. Food, housing, employment, income, pollution, transportation, there's a bunch of them. The slides that are on, or the pictures that I've put on this slide are just sort of pointing out why this is a big deal. So social determinants influence 50% of health incomes. 50% of health incomes are actually related to social determinants. That's mind-blowing. Recent survey findings show the prevalence of unmet social needs that impact healthcare: 35% food, 25% safety, 21% housing, 17% social support, 15% transportation. I mean, unbelievable that these are unmet. That's the proportion of unmet needs for things that are determining your overall health and lifespan. The one that's got the red circle around it, I put that circle in. You can't really see it, but it says 1 in 7 US children are living in households with food insecurity. 1 in 7. I mean, that's just unbelievable, but it's true. And the part that you really can't see, but is the reason I highlighted it, is because it says the COVID-19 pandemic has increased this. I think it said to 1 in 4. But basically, at baseline, food insecurity is a huge problem, and during COVID, food insecurity is, an even huger problem. So these things matter. It's challenging to screen for social determinants of health. It's hard to ask these questions in a way that sounds like you're trying to be supportive and helpful. It's hard to know what to do with positive answers. And that's just, it's going to take some work to sort of figure out, okay, now that I know this, how can I actually make a difference? And that is beyond the scope of this. But I did find that there are some pretty good screening questionnaires that can at least help identify the problem. And even if you can't fix the problem, knowing that there's a problem is the first step, obviously. And the AAP wants us to screen for this. So next slide. So at least annually at all well visits. And if you're not in like a practice, I think at least annually, with wherever you're working, if you're interacting with kids. So next slide. So this is an area that it's actually kind of hard to find questionnaires. The three, so the hunger vital sign and SEEK have been around for a while and are getting to be better known. We'll talk about each of those. And then this North Carolina Department of Health and Human Services, for the state of North Carolina, the DHHS put together a whole kind of research project with the goal of being able to better identify, and they ended up with this screening questionnaire. So I'm not sure it's even a formal kind of, it's not gone through the same process, I guess, as the other questionnaires that we've talked about, but it is out there for public use and covers some of the social determinants of health. So I think it's a good option. We were moving towards using this screener as I was leaving the practice, but I did a lot of research, not a lot, but I looked into SEEK for this talk and really became very impressed with SEEK and the whole toolkit that SEEK has to offer. So another good questionnaire. So go ahead. Hunger vital sign, that was kind of the very first social determinant of health that the AAP recommended. The hunger, there's a lot of different ways to ask about food insecurity. One of those is what's called the hunger vital sign. You can see the questions right here. It's validated, it's standardized, it's got very high sensitivity. It's not as specific, but still high specificity. And it's been shown that children who are screened at risk, who screened positive basically on this hunger vital sign, were 56 times more likely to be in fair or poor health, 6%, sorry, not times, 56% more likely to be in fair or poor health, 17% more likely to have been hospitalized, 60% more likely to be at risk for developmental delays, just from one question about food insecurity. I mean, obviously, you can all understand the bigger picture of food insecurity at just a basic level, but even when looking at outcomes, a positive screen from food insecurity has a massive impact on a child's life. Next slide. So SEEK, I think I have several slides on SEEK. It asks about more areas of social determinants of health. So it does include the food, the hunger vital sign in it. It includes parental depression, and I think that's with the PHQ-2, yeah, as I'm looking at it right now. So it includes the hunger vital sign, the PHQ-2 for parental depression, or even, you know, as they're getting into adolescence and certainly young adulthood, you would give this directly to the patient, and that depression screen applies to them directly. It's obviously not the craft, but it's got substance abuse in there, major parental stress, intimate partner violence, and then harsh punishment. So as I was looking into this, it was pretty, you know, questions are not always super comfortable to ask or answer, but there's a little kind of section at the top that explains why we're answering. And the questions are really, you know, they're just kind of, I don't want to say black and white, but they kind of take the stigma out of it. It's not asked in a way that feels stigmatized. It's just, hey, has this ever been a problem for you? And there's a great toolkit and website that was super easy to find. So the website, the link is available in the shared folder. And that's how I got all my information on it. And I feel like I kind of like learned how to use this questionnaire from start to finish just in my research for this presentation. So it's got a whole bunch of background. It's really easy to read though. I did not ever feel like I was reading like pages and pages of text. It was like bullet points of, you know, why does this matter and why this tool works. My house is incredibly loud today. That would be my son who is homeschooling today. All right, yeah, got off topic there. So let's see. Okay, so it includes training videos showing you how to implement it, management algorithms, so what to do if you come up with positives. There's parental health handouts and national resources. So it does begin to address, well, what if it's positive, what then? You can go on to the next slide. Really busy slide, but this is just showing you that kind of the treatment algorithms that it goes through in the parental resources. So there's one of these algorithms on the left side of the screen for every question that's asked on the SEEK. So helping you to ask more questions if there's a positive to better figure out what's going on. Parental handouts, addressing barriers, that's what that kind of middle section is. But so for every question on SEEK, there's this huge toolbox of how to sort of get more information. Is this a problem or not? Resources. I was looking, this one on the bottom, intimate partner or domestic violence, IPV. That's an example of national resources. So when you click on, when you're working through the intimate partner violence section of this and you've determined there is actually something to be concerned about, well, what do I do? Well, those are national resources that can help you and patients figure out what to do. Information you can give to them, contacts you can give to them. So it doesn't sort of leave you hanging with what now. It actually gives you a lot of tools to kind of follow through with some of these things. And I think that's really a huge benefit of Seek. In addition, the other huge benefit of Seek is it just takes you right through the whole process, kind of question by question. You don't have to do that with every patient, but anytime there's a concerning finding on the Seek, it's pretty easy to just follow their process of, okay, well, let's go down this pathway and here's the things that we need to do to kind of get a better handle on this. And it's free to use. I don't know that it's always free to use. Actually, go back to the previous slide. Electronic version for administration and research distribution is available. Use of Seek requires a license agreement, which may include a fee. Oh, and then I have my little bullet point or my little asterisk down here, which is just a plug for the Ohio chapter of the AAP is, and has for years, done this Seek plus injury prevention project, but they are starting a new wave like right now. Like I think there's still time to join. So if you are interested in using this questionnaire, that project will basically hold your hand and walk you through the entire process of how to implement this questionnaire successfully into your practice. So Olivia Simon, that's who you want to get in touch with, but you can also just reply to Alex or anything from this presentation and ask who to get in touch with. That's an exceptionally great way. That's actually how I learned so QI, my very first QI project was called CADLAC. It was Concerned About Development Learning Collaborative is the first time I ever did formal QI. And it's where I learned to use the ASQ3, I don't know if it was the 3 at the time, but the ASQ and the MChat. And it takes it from, I don't know anything about this questionnaire to I'm now giving this questionnaire to all age appropriate patients in the office with success. And we're still doing that today. So I would highly recommend doing a project like that if you're looking to implement a questionnaire, particularly Seek. All right, so next slide. We already talked about, and then next slide. So this is the one that I call North Carolina, but it doesn't really have a name, but you can see it just addresses, again, it just kind of asks a question or 2 or 3 about specific areas. This one covers food, housing, utilities, transportation, interpersonal safety. Next slide. Okay, well, that's that. Transition. So again, any questions on that is all the questionnaires, the specific screening questionnaires that I had planned to talk about today, covering the top 5 recommendations for preventive care screening for cognitive, developmental, and social emotional concerns. So I don't see anything coming up in the chat slide. The rest of this, and it's there's not that much more, is just how to make it work. And I'm not going to read this slide to you, and it's certainly not anything that you would ever be tested on. There's no pop quiz at the end, But if you were looking at implementing, this is just a resource tool of how to go through that process. So you got to think about what tool you want to use and what the workflow would look like, and you know, how you would go about screening and documenting and billing and all that. So this is just sort of a reference on how to go from nothing to implementation of a screening tool. Next slide. This is just a sample. It doesn't have to be exactly this. I think this is mostly what my practice did or does, incorporating all the Bright Futures recommendations at the right age group. And this is just a selection of screening tools that we use that we thought worked really well. I already told you I didn't do the craft, but it is important to do substance abuse screening, so it's in there. And then back to the question about using PHQ-2 for maternal depression screening, that's what we did, so that's what's in this. So just an example of, you don't want to overwhelm any one visit with 10,000 questionnaires, and so trying to kind of sort it out into, you know, keeping it to the minimum that you can get away with at these various age groups. So this, if you're going to start implementing screenings, obviously you're not going to do it all at once, but you want to have sort of a bigger picture of how many of these recommendations eventually am I going to want to include, and what tool am I going to want to use, and then what age would that be done at. Next slide. Sample workflow. So this is, again, just kind of for reference. What might it look like to utilize a questionnaire, a standard questionnaire at specific age groups or specific visits? So clearly I forgot to tell my family that I was giving a presentation. It's lunchtime at the homeschooling house of the Crick household. All right, so this is just, it doesn't have to be exactly like this, but just as an example, there's got to be some pre-visit planning where you figure out who's coming in that needs a questionnaire, what questionnaire that they need, how are we going to get it to them, what's going to happen in the office in chronological order of how does this questionnaire move through the process of being administered and completed and reviewed and billed. So again, reference slide. Next slide. Coding is kind of the last major section. Again, this is going to be a reference slide, but I did put what the appropriate CPT code is for each of these questionnaires that I've included in this presentation. CPT codes are the procedural code for administration of a procedure versus ICD-10 codes are diagnostic codes. So this is, I gave a screening questionnaire. I took the time to give a questionnaire, score it, review it, document it. That work has a value to it, and that it probably has a value that's higher than the price or the cost, but that's cost is what you get reimbursed by using this specific code. But you have to use these codes to get reimbursed for the tool that you've used. Next slide is ICD-10 codes. So yeah, totally overwhelming. This shows you all the ICD-10 codes for social determinants of health. So there's obviously a lot, and this would just require it's not going to be this exact resource because obviously it's all cut off and pasted over each other, but a resource of what ICD-10 codes to use when you're coding for a positive social determinant of health screen. For example, food insecurity. If you've got a positive screen, you'd want to use the appropriate ICD-10 code to support the level of service. So diagnostic codes support your service code, CPT codes bill for your code for your procedural codes for the actual questionnaire itself. Next slide. Okay, so I just had some examples, and it looks like I've talked for way longer than I ever thought was possible, but let me give you we can kind of quickly go through a couple of these examples for billing. So the examples came from, well, this source that I have on the left, Medical Home Portal. So we're going to do example 1, 3, and 5, and that's just what I picked out from their example. So a well child check with routine screening, you don't need to worry about the ear infection part of it, although you can look at that if you're interested. Doesn't have to do with this particular presentation. But so you did your well visit. You obviously have a ICD-10 code for that, as well as a CPT, or that's your level of service, your CPT code. For the screen or for the well child check, but you did a screening that's recommended and validated and qualifies for a procedural billing code. That's your 96110. And this one, you've times that by 2 because it's an 18-month-old and you did both an autism-specific screen and a developmental screen. So you would bill twice for that code. That's the procedural code for developmental screens. Next slide. Routine adolescent health check with new concern for anxiety. This is the like, oh my gosh, this is going to ruin my whole day. But at least get paid for it if it is going to take up your whole day. So you did a well visit on a 17-year-old. As part of normal well visit in adolescent, you did a PHQ-9 and a CRAFT 2.1. And so you bill for those with your procedural code. That's the 96160. That's in the slide that I showed you previously. Patient-focused health risk assessment instrument. Actually, that's the CRAFT. CRAFT is a 96160. And a PHQ-9 is a brief emotional behavioral assessment, PHQ-9. So that was just part of your routine screening. And then the adolescent disclosed significant amount of anxiety. So you looked into that a little bit more, did a scared version, or if you use these forms, I like the GAD-7. It's way better than the scared. It's an awesome questionnaire for anxiety. So that both of those would qualify also for a brief emotional behavioral investment. So you did routine screening with the PHQ-9 and the CRAFT. And so you bill those procedural codes, one for each of those. And then the scared is another procedural code, but this happens to be the same one as the PHQ-9. So you would bill for those 3 different procedures. You can see over on the ICD-10 side, that's just supporting. So you have your well child check. You did have abnormal findings because they went ahead and added a secondary service with a 25 modifier. Encounter for screening examinations for other mental health and behavioral disorders. There's Z00.121. I'm not actually sure what that stands for, but I bet that's generalized. I don't know. It seems to me that this one is missing actually your generalized anxiety. So it says you have abnormal findings, you identified generalized anxiety, so you'd want to code for that as well. However, that has nothing to do with the screening presentation. So the ICD-10 codes, if you're going to do screening, there's generally a ICD-10 code that just supports why you did that screening. Next slide. Development and autism screening at an unrelated sick visit. So here you don't have your well visit ICD-10 code. So you need an ICD-10 code to support why you did the screening. And that's listed on the right side, screening for global developmental delay. I mean, maybe this kid, I don't know, missed getting the screening for some reason, or the parent had a concern for some reason, but for whatever reason, if you did it outside of the context of the well visit, then you have to, or you should include why did you do it, because it doesn't actually have anything to do with the otitis media that you're coding for. And then you would include the 2 developmental screens for autism and development with the 96110 times 2. Next slide. Look at that, I'm done. So I know there's a few more slides that Alex is gonna show you before we're actually done. I am in total disbelief that I actually used 1 hour and 25 minutes to talk. But yeah, obviously if you have any questions, either chat at me, or I'm sure Alex will be giving out the my email and contact information. Love to hear from you if you have any suggestions, advice, questions, anything I can help you with. Thanks for putting up with my talking husband and my homeschooling drama and my dog.
Great, thank you so much, Dr. Cook. That was great and so helpful, learning about the different questionnaires and how to best implement them. So that was great. Let's see if there are any questions now. Please let us know. If anything comes up later, you can always send me an email and I'll let Dr. Craig know that you had a question and we can get the answer back to you. As far as the Pmp resources, I just wanted to go over those a little more in detail. These are available on our website and on our Pmp mobile app. We have them on Play and Hunger Cues. We have a new one on Playing Inside during winter and during COVID. So we will be sharing that with you all soon. We're going to have a new one on complementary feeding. We've been editing a few handouts, so I'll be sending out an email about that soon. And then these are just some more age-specific handouts that we have available. Again, you can download them on the mobile application on the App Store or Google Play. And then this is the survey that you can copy and paste to get your certificate or your CME and MOC credit. I also wanted to touch on the toolkit again one more time, just to let you know that you can download that, register for the toolkit. Let me know if you have any questions. And then, as always, you can send me an email if anything comes up. And then Dr. Craig clicked on the link. So this is what that evaluation looks like. And I will also post that into the chat.
Yeah, I was going to say, put that into the chat because I wasn't actually able to bring it up. Also, did you, and I may have just spaced out, but did you give them a way to get into the shared folder with all the resources?
That I'm going to send a follow-up email, and that link to the shared folder with the resources will be in there. The slides will also they're already there, so they will be there for you to look at. And then any questions that you have after I send that out, please let me know. I will also send a link to this recording. So if you want to go back and listen to Dr. Crick again or share it with your colleagues, that's also a great idea. Any questions, as always, my email's here. If for some reason you don't get the email today about the survey, I'll be sending it out soon by the end of the business day. Please let me know, send me an email. Sometimes emails get mixed up with the registration link. Again, please let us know if there's any questions. Thank you again to Dr. Crick and ODH for their support with this training. And we appreciate you all joining this. Our next training is on Monday, March 8th. Dr. Mike Gittleman, Dr. Denny, and Tess Steiner with Nationwide Children's will be presenting on mental health and the suicide prevention program. So we would love for you to join us for that if you're able to. Great, thank you everyone. Thank you, Dr. Crick.
Thank you.